think with that, we move on to our second speaker in the session, which is Dr. Kaushik Murali. He'll be speaking on workplace assessment and application in the clinic. I think it straddles a little bit of what Dr. Prashant must have spoken.
Again, a personal note of thanks once again for accepting the talk. Literally less than 24 hours to go. Thank you.
So again, my talk is going to have two objectives. One is to cover what work-based assessments mean and how to actually apply it in the clinic. Again, I'd like to acknowledge Dr. Meenakshi for sharing some of her slides, some material that I've incorporated as a part of this presentation. So when you look at workplace-based assessment, the definition says that it is the assessment of the trainee's professional skills and attitude, and it should provide evidence of everyday clinical competence. So when you look at the definition, there are two words that are not necessarily highlighted, but when you want to actually implement it, becomes critical. One is to understand what does competence mean. Second is what is assessment. We've spoken a lot about assessment through the day. Competence has been defined by Dr. Carl Golnick in his paper as the ability to do something well. Now again, that is kind of vague, but I think over a period of time, it does stand out whether that competence is there or not there. Assessment again is judgment about knowledge, practical skill, attitude, and behavior, but you need do this against a known standard. When we look at workplace-based assessment and when we're looking at the newer modalities of training and teaching, there are again two aspects of assessment that typically happens. This again happens innately in our households, where we kind of assess our children or our children assess us, as well as in a school environment or at the workplace. So one is a formative assessment where the feedback is part of the personal learning and professional development. The summative assessment is like a movement to the next stage in their life or next stage in their career. So there the decision is about moving them up and progressing them. Now let's go back to the time when each one of us was a student. From school through college, medical school, postgrad, fellowship, some of us have been brave to take some more exams, but invariably these exams have been a high-stake kind of a event where you receive a grade, you're judged on that particular day that you have passed or that you're a failure. The consequences again can be varied. It can be either embarrassing because you thought you were a brilliant student but you did not stand up on that day, to possibly a derailment of your career, especially if you're looking at a fellowship entrance where it puts you off by a year. And here, there is no question of you asking the assessors, especially in a situation like a DNB exam or an MS exam, where you have no clue what marks have been awarded to you. So there is no feedback, there is no way you know where you've gone wrong or where you can improve. From here, we are now talking about a workplace-based assessment, which is actually looking at something that's happening in your workplace and looking at your clinical competence, not necessarily giving you marks in terms of what your knowledge is, like the last slide Dr. Prashant shared. Which is very apt in that we are not looking at knowledge, but actually looking at how you're applying that knowledge largely here. So all of us are part of some teaching program, and if we had to ideally structure it, like has been shared by Padma Malini ma'am, you would have an induction program where you're kind of setting context as to what the trainee can expect during the tenure of that program. Then there is some systematic teaching that happens. There is a framework that is there, there is a schedule that is there, and this teaching, the topics or whatever is being taught is based on a particular curriculum. In between is an area that possibly we sometimes miss, is of the workplace-based learning and assessment. That becomes very, very critical because that then allows you to make sure that you're giving an ongoing feedback back to the trainee and also receive feedback as to whether your training program itself needs to be tweaked. Because often we are teaching our students the way we were taught. Possibly they need a different way of being told what they need to learn or how they need to learn. So this kind of works both ways. And this allows a holistic approach and is a lifelong kind of a learning that you tend to then imbibe as a part of it. Now, this is a given saying that this is something that needs to happen. Then why is there a need to actually formalize this whole thing? First and foremost, a lot of our clinical colleagues are not good at observing clinical skills. They're brilliant clinicians, but they are horrible as teachers. So it is not a given that every good clinician is a teacher. The vice versa is usually true. At the same time, they document certain things which may have happened, or they may also carry forward biases of previous incidents with that same student. So generalisms of saying you're always like this, you never turn up on time, you're most undependable. These kind of generalisms kind of creep into play. And sometimes, again, it flips to the other side, where some of our colleagues are extremely gracious in giving an immense benefit of doubt, saying that, oh, possibly they are overworked, poor things, they don't know how to handle stress. They can't handle stress, probably they should not be in this profession. It's a given that we are handling somebody's life and eyes. So some amount of tension is part of what we've signed up for. And people always don't like to be the bad apple, so they want to be always good or known to be the good person, so they don't like giving feedback. And we have huge egos. As teachers, trainers, doctors, we don't want to be told we are wrong, because we know what we are doing, and that again kind of comes back to it. Again, I think Apurva, through her problem resident, did share, saying that we may love to teach, that doesn't mean that the other person is learning. So to assess that, a rubric or some kind of a metric becomes again very important to gauge as to where that person is. Now let's look at this 4-box thing, where a person is either consciously competent, which is great, they know that they're very good, or they're unconscious about their competence in that they lack self-confidence and they otherwise are very good. They always think that they have much more to do. Other end, they are unconscious about their incompetence and that they have no clue what they are. They are gloriously ignorant and they are blissful in their existence. And the last bit is they're very conscious they're incompetent, like we shared earlier about somebody being thrust into a program that they possibly don't want to learn. Now, does a workplace assessment actually have a role play in this? Now, if you go back to how we defined it, work-based assessments facilitates us to observe a student, give them structured feedback in real-time clinical settings, and we believe that there is a possibility of improvement. So we go back to that same grid, we go back to the person who is consciously competent, asking them, saying, what do you think you did well? To somebody who is consciously incompetent, asking them, saying, what do you think you could improve? Or somebody who is unconscious about their incompetency, you be gracious and tell them, saying, I think you can actually improve if you did 1, 2, 3, 4, 5. And who's unconscious and competent, you bump up their confidence by telling them, saying, I think you are very good at this. So that way, this workplace assessment allows you to kind of go back to that student and go back to where they are. What are the tools that we have in play? Now, you'll see a whole lot of abbreviations here. They look extremely complex, but actually they're very simple. So OCEX is the ophthalmic clinical evaluation exercise. DOPS is the direct observation of procedural skills. The mini CEX is again, sorry, apologize for that. It is again a mini clinical evaluation exercise. CBD is case-based discussion. OSCAR is how you look at the surgical competency. And MSF is what Dr. Prashant presented just now, which is the 360-degree feedback mechanism. Now, a student who walks into our system has different layers that he has to go up before they achieve a level of competency. And based on how they enter in, initially you may have to look at only their knowledge, because they may not be competent. They have no clue what they're supposed to do. To end of the training program, where you're largely looking at how they're actually functioning in their work-based scenario. There you are not interested in how much of theory they know or the science they know, but larger how they are dealing with their patients in a real world. Now, let's start off with the OCEX. This is actually one of the most comprehensive tools. There is enough published literature available about it. Here, the resident looks at a new patient with the evaluator sitting in the room. They rate the resident and the feedback is immediate. So those are the most critical aspects of this. Again, this gets broken down into multiple layers, right from how they introduce themselves to how they elicit the history to how they look at the medication list. You can judge them into being a novice, a beginner, or a competent, or that particular line may be not applicable to that patient. What do I mean by that? A person with conjunctivitis, possibly they don't need to do a confrontation field. So you can't say that, oh, he's a novice, he didn't do the confrontation field properly. So for that line item, you will put it as not applicable. Therefore, that examination varies to that particular patient. Then it goes into the various examination, their interpersonal communication skill, where you're looking at their holistic ability. This also can be used in a case presentation format, where you can actually look at how they are looking at the whole area of it. Just in a very simplified form, the mini CEX is something that you do when you're lazy and you don't have time to do a complete examination. It's a kind of a simplified version of it. This can be done in the clinic. This is something that possibly we routinely would do, where we ask the patient, look at a patient, and then you comment about how they've done or what they've done. We don't usually do it with a rubric, but it's a great idea to do it with a rubric, because then there is some method to the madness. DOPS is again something where you're looking at the procedures and skills. Clinical judgment, critical thinking evolves when they do case-based discussion. And you can bring in some amount of professionalism by critiquing them by getting a 360-degree feedback done. This is a video courtesy Dr. Meenakshi.
Ready.
Again, it's something to keep you awake post-lunch. I know the long walk did help us digest most of the food. But this is, as you can see, of a pupillary exam being done. Now, has that person done this exam properly? So what are they, a novice, beginner, competent, or incapable of doing it? So they're possibly a
Ready.
novice because if you look at the pupillary reaction, a novice does not check, but actually they're a beginner because they did a part of the exam. So this is how the rubric adds up. So if they did not even do it, then you would have called them a novice as per this rubric. So that is where I think a little bit of a change happens in terms of the nomenclature we use and how we actually grade them. This helps us in terms of getting it done. Next, looking at the mini-CEX. This again evolves from history taking to communication to judgment and professionalism. Again, I'll show you a short video. This was something that we got shot today morning. Here, I would like you to comment on Dr. Saptagirish, who's playing the role of the evaluator, saying that is there something different that you would have
Do
done?
this 2 times a day for a week. I'll give you one antibiotic drop to use only in your right eye for the swelling. Use it 4 times a day for 1 week and then stop. For the allergy, I'll prescribe you 1 drop, and for dryness, I'll prescribe you 1 drop. Allergy drop, you have to use once only at night in both your eyes, 1 drop for 1 month. And dryness, you can use a drop which is called Lubrex, that you have to use 1 drop 4 times a day in both your eyes. So morning, afternoon, evening, night, and use it for 1 month. You can continue using it as in when you feel that your dryness is coming back, but just get a new bottle every month.
And what should be the gap between 2 drops, since you are
Keep a gap of 5. Only the coinciding drops and that antibiotic drop will be there, so you can keep a gap of 5 minutes between 2 drops. Okay?
Yes.
You can wait outside, I'll just give you a prescription.
Thank you so much.
No problem.
So as you can see, he almost fell asleep through the discussion. But apart from that, what would you have done if you were an evaluator in the room? I think that would be something interesting to ponder and look at. Yeah. So you could have asked him to paraphrase, possibly.
Yeah, because this is, looks like a patient who's educated. So you write it out or print it out, give it to the patient to hold, and then go through the drops.
Correct.
Might be easier.
Yeah. So there you've seen that just because you're sitting in the room and evaluating, maybe it's not always appropriate. It's again good as an evaluator also to hold a rubric or a paper in hand and then look at it. So this again is a very famous ophthalmic personality who did our exit evaluation for one of our oculoplasty fellows. So here what you see happening is a DOPS happening. So here we actually asked the fellow to perform a surgery in Akshay's presence, and he kind of assessed her ability, evaluated it, and also performed and gave feedback to Dr. Samia in terms of what she had done. Again, for DOPS, it can range from clinical procedures to even surgical procedures that you can actually implement it. I'm going to pass this on because we've just had a long talk about 360 feedback. This again looks at identifying competencies, strengths and weakness, and it is supposed to look at professional development. So whenever there's a 360-degree feedback, it is important for us not to get personal about it. So that is something I think we need to remember. When should all these assessments be done? It should be done pretty much through the training program, at least during the formative period, as well as a summation in the final year. The formative periodically allows you to kind of give feedback. The summative helps you in evaluating whether the person is capable of passing through that program. And it is important for this not to become something that is ad hoc or a department comes and does, but becomes an inherent part of the day-to-day clinical work itself. This does require an inherent cultural change because it will look like you're wasting time not seeing patients by doing this evaluation. But over a period of time, it does build a lot of efficiency to it. To the individual, one, they're getting feedback. The trainee knows where they're going right, what they're doing wrong. They get motivation, they get encouraged. They kind of are told that they can do much better. And it also shows progress, saying that the last assessment you did 1, 2, 3, 4. Now you've done 3 more additional tests. So it kind of allows them to understand they're doing better. For the training program, what we've noticed is it gives us evidence in terms of whether we want to take them to the next step. If you want to recruit them, if you want to move them to another program, what needs to be done? Also in trainees and difficulty, we've sent a couple of our trainees who were not able to do cataract surgery actually to Akshay to make them work on a simulator in Bombay. And we've seen this person who was struggling to put a section now be able to do about 10-15 cases a session very easily. So that this kind of a summative assessment allows you to take those decisions where there is an investment of time and money. In our experience, what we've noticed is that you may not do it in complete 100% the way it is structured, but at least the logic of all these tools can very easily be incorporated as a part of our training. It does bring some amount of seriousness. Like Akshay mentioned, these are exams, evaluation. When we tell them somebody from outside is going to take your exit exam for fellowship, suddenly there's a fear of God that comes into them and they start studying for it because they don't want to be shown in bad light to somebody outside of the system. This does allow active interaction, the fellow and the consultants, because they're periodically speaking to each other. And there is a lot of critical assessment that happens where you're pinpointing them on particular attributes. And we've seen case-based discussion especially inculcates a lot of critical thinking because they're now looking at differential diagnosis and trying to solve a puzzle. Challenges are, again, with students, it's usually just in time because this is a grade. So there is no tangible mark, so they don't feel any value. So that, again, creates a lot of problem. With assessors, our colleagues, again, either they don't have time or they say that they'll just fill something, or sometimes they take it so much to heart that they become too critical and too harsh that the student completely gets shattered and they have no idea why they're even in ophthalmology. So in conclusion, work-based assessment and any of these competency metrics helps you look at the performance in a day-to-day practice. It gives you evidence to look at how they're learning and reflect on real experiences. And it supports learning in important areas of capability. And finally, I think it makes the trainee ready for the big bad world. Because one, they walk out with confidence about their competency, and they build a mentor-mentee relationship. Like Padma Malini ma'am said, they will send a WhatsApp message saying, this is the case, I'm stuck, what do I do? So they have that confidence that there's a shoulder that they can lean on for the rest of their life. So thank you so much, ma'am, for making me part of this session.
Thank you so much, Kaushik. That was, brilliant. Now, hereafter, I know who to request for talks.